I'm Dr. Albert Arias, and today I'm going to teach you the basics of using medication to treat alcohol use disorder in your primary care practice. The main goal of this presentation is to give you a quick tutorial about the major first and second line medications that are available and that are evidence-based to treat alcohol use disorder. I hope that this will help you get more comfortable with using them in your current practice. So first, let's talk about how these medications work. Medications for alcohol use disorder, or AUD, are often referred to as anti-craving medications, and that is true for some of them. However, there are possibly more mechanisms by which they work. Generally speaking, the two most pronounced ways in which we think most of them work is by decreasing craving, otherwise known as the urge to drink alcohol or the learned anticipation of drinking alcohol, and by reducing the euphoric and other positively reinforcing effects of drinking. It may also be the case for some of the medications that they help reduce the negative reinforcement of drinking. So for example, if a medication treats the anxiety and insomnia often experienced early in attempts to be sober or cut down drinking, the patient may feel less inclined to drink alcohol again to relieve those symptoms. There's one medication also, called Disulfiram, which causes an aversive, unpleasant reaction when a person drinks alcohol while on the medication, which is a different approach. When considering whether a patient is a candidate for AUD pharmacotherapy, it's reasonable to consider any patient that meets the DSM-5 criteria for AUD, and you can also consider any patient that regularly exceeds the recommended safe drinking levels but doesn't appear to meet AUD criteria, especially those that have frequent heavy drinking days. It's also quite useful to consider referring the patient to a counselor or therapist that can provide evidence-based psychotherapies or psychosocial interventions to treat the disorder. Most of the medications have been shown to be efficacious for many patients without concomitant psychotherapy, but it is often advisable to refer for those services along with medication as part of a patient-centered approach. Some patients probably benefit from both or will need both. The goals of treatment may vary somewhat depending on the severity of the patient's AUD and their comorbid conditions, but generally speaking, we want to prevent the progression of the illness, prevent the psychosocial and medical consequences of ongoing heavy drinking, prevent relapse to harmful drinking patterns, and reduce the long-term morbidity and mortality of the illness. Many medications have been studied for the treatment of AUD, but there are several in particular that are approved by the FDA for treating the disorder, and there are several that have a decent evidence base for use. We're only going to discuss the ones that are FDA approved for AUD treatment in this brief lecture. Topiramate and gabapentin have evidence to support their use and could be considered by practitioners who feel comfortable prescribing them. Naltrexone is an opioid receptor blocker that works by modulating the release of dopamine in the reward circuits of the brain. The effect is thought to block or reduce the positively reinforcing effects of alcohol use, like the euphoric effects, and also reduces craving or the urge to drink. It has been shown to be efficacious in reducing heavy drinking and has a small effect on abstinence measures also. The usual initial target dose is 50 milligrams daily, and it can be started at that dose or given initially at 25 milligrams daily for a few days to a week and then titrated up to 50 milligrams daily. Note that naltrexone is also available in a monthly injection that is FDA approved for both alcohol and opioid use disorder. Note that the oral naltrexone is not recommended for opioid use disorder treatment. Naltrexone is a fairly safe medication, and the common side effects are usually gastrointestinal symptoms and headache. These often subside after a week or more of treatment. There is a rare risk of hepatotoxicity, though at the doses described in this lecture, this is thought to be very rare. Acamprosate works by modulating glutamatergic receptors, and likely also facilitates GABAergic neurotransmission. This probably decreases the urge to drink and is active in modulating reward-related circuits. Acamprosate has a substantial body of evidence to support its use and is efficacious in terms of improving abstinence measures. Acamprosate has a substantial body of evidence to support its use and is efficacious in terms of improving abstinence measures and related outcomes and reducing the risk of relapse. It can be started at the full dose of 2 grams daily divided over 3 doses, TID, although often it's titrated up after a week of 1 gram daily, also divided over 3 doses. The medication has a long half-life, but bioavailability is not great, thus the need for TID dosing. Acamprosate is a very safe medication. Generally, it's very well tolerated. Notice, like Naltrexone and many other psychotropic medications, there are rare occurrences of suicidal thinking and behavior that are attributed to the medication, but this is rare. It is cleared renally, and it is contraindicated in those with severe renal impairment. Disulfiram, combined with alcohol, creates a reaction which is very unpleasant, thus producing an aversive influence on drinking. When patients are left to their own devices, this medication has not proven to be efficacious. However, studies have shown effectiveness of the medication under certain conditions, particularly when the patient's family or spouse are involved in a social contract supporting adherence to the medication. Its effectiveness is supported also by studies of active controls, naturalistic design, open trials, and meta-analyses. Disulfiram can have a number of severe side effects, which are not common, but certainly can occur in the course of treatment. The disulfiram-ethanol interaction can cause cardiovascular strain if a severe reaction occurs. It is contraindicated in pregnant patients and those with significant cardiac disease. Generally, we don't use disulfiram in patients who have already done substantial damage to their livers or are in acute hepatitis or liver failure due to the risk of concomitant hepatotoxicity. Naltrexone is also not used in patients with acute hepatitis or liver failure. However, it can be considered in stable patients with chronic liver disease if they are monitored closely and appear to have clear benefit from the medication. Often in such patients, there are better or other options for treatment. With regard to the general treatment approach, it is useful to consider a patient-oriented, patient-centered approach to assess the psychosocial factors in the patient's life and to ask about their goals for drinking and health. It is useful to check in with the patient frequently during the initial stages of treatment. Brief interventions, other psychosocial interventions, and referrals for mental health care and assessment are important to consider. Because naltrexone and disulfiram have rare but possible hepatotoxicity, liver function tests should be checked frequently during the first few months of treatment and then at longer routine intervals with extended use. It is also important to consider medical comorbidities when prescribing these medications. When should a medication be stopped or switched? Failure to respond after several weeks or more of treatment would suggest a need to try another approach. Severe side effects should be monitored for and changes made accordingly. Studies have shown benefits to treating with medication at 1 year of treatment, and most experts will consider recommending up to 2 years of treatment with a medication or longer if beneficial. Some patients benefit from shorter durations of treatment. Well, I hope you found this brief introduction to AUD pharmacotherapy helpful, and I hope that it helps you improve health outcomes for your patients. Thank you very much.